Thanks for the opportunity for me to present this talk. My name is Darren Roberts. I work as a clinical pharmacologist and a nephrologist. I work at a number of hospitals in Sydney, as well as the University of New South Wales. Although today I'll be talking about TDM in general, I will attempt to relate this to antimicrobials specifically. So in terms of an overview, today we'll talk about definitions and scope, and I'll compare TDM and TCI. Talk about why to perform TDM, to be aware of some of the possible assumptions and limitations of TDM, and also the impact of TDM on the prescribing process. So definitions and scope. This is just to make sure we're talking the same language. It is important in this context because there are so many definitions, and so depending on our perspective, we may see this a bit differently. I've chosen to reflect on the definitions by the International Association of Therapeutic Drug Monitoring and Clinical Toxicology. They're a multidisciplinary clinical specialty they describe that TDM aims to improve patient care by individually adjusting the dose of drugs for which clinical experience or clinical trials have shown an improved outcome in the general or special populations. It can be based on a priori information or a posteriori information. We'll talk about the a posteriori information in a moment, but I think it is important to remember that they're noting here it's a clinical specialty, it's multidisciplinary in most cases, and it's guided by evidence. And so it is important that we have evidence. We therefore need to remember its limitations as to whether or not the data applies to special populations or if it can be generally applicable. So ATDM-CT goes on, and sorry this is a bit of a wordy slide, but in the case of a posteriori TDM, they mentioned a few things. First of all, this involves both pre-analytical, analytical and post-analytical phases. Each has the same importance, and of course that makes sense. If we have a fall down in one of these processes, then all of the others are no longer useful. It mentions the importance of specific, accurate and precise, as well as timely determinations of either drugs or biomarkers or other surrogates at appropriate times. When we're talking about drug concentrations, that's PK, pharmacokinetic monitoring, and when we're talking about other biomarkers, it's PD or pharmacodynamic monitoring. In general, with antibiotics or anti-other microbials, we're talking about PK monitoring. But then it goes on to become more complex. So it requires the interpretation of the results, taking into account pre-analytical conditions, clinical information, and clinical efficiency of the current dosage regimen. And this may involve some degree of PK to PD modeling. And then through the possible use of population PK/PD approaches combined with individual pharmacokinetic forecasting techniques, we then act on the information that is received. And so this is becoming quite specific and requires expertise. This is what a lot of this workshop is about, is talking about these various techniques. So importantly, therapeutic drug monitoring is not therapeutic drug measuring. We need to not only measure, we need to act on that, and we need to follow it up. And I know I'm preaching to the converted when I talk about this at this meeting, but it's still useful to remember, I think. So what is TCI? TCI is a target concentration intervention. So this was a term that was first defined about 20 years ago. The authors of this paper, which was recently published in the British Journal of Clinical Pharmacology, describe three principles of TCI. The first is to define and use a target, e.g. drug concentration or biomarker, to guide the dose required for optimal treatment. I think this is something that many of us do as part of TDM. Indeed, that's what most of this morning's sections have been about. To use pharmacological principles to predict the dose required to achieve the target. And again, I think this is something we're talking about and something that's been reflected before, and certainly something as a clinical pharmacologist and nephrologist I spend some of my time thinking about. And similarly, as a clinician and a prescriber, I also do this. I apply an intervention method for using an individual patient measurement of response to recommend the next dose to achieve the target. So these are factors that I would incorporate in what I think is TDM. The authors compare TDM to TCI and talk about how they differ. And so I think a number of these things relate to perspectives. So I certainly agree with the authors of this article who are promoting TCI, that these principles are very important, and these are certainly things that I do myself in practice, and I'm sure you do too, and I'll come back to these. So why do we perform TDM? Well, it's very important when a clinical endpoint cannot be measured in a timely manner. The drugs that we're talking about, antimicrobials, do not have an end of needle effect, meaning that when we inject the drug or give it orally, we do not see the response that we desire almost immediately. What clinical endpoints would we think may be useful? Well, I guess in the context of infection, changes in blood pressure or heart rate, temperature, changes in the white cell count or markers of inflammation. These are factors we generally look to resolve with treatment of antibiotics, but they're slow to change, and they may also be influenced by other factors as well, and therefore we can't be certain that a lack of response or a response is due to the fact that our antibiotics are at a therapeutic concentration. So an antimicrobial drug concentration is an ideal target. Most of the this morning was spent talking about different target concentrations for different antimicrobials. They're a diverse group of compounds. They've got different pharmacodynamic indices associated with bacterial killing. Therefore, they have different concentration targets. So we really need to individualize what we're measuring in the context of antimicrobials. A similar principle to this, which applies to other drugs, relates to when we do TDM for the purposes of prophylaxis of a condition. For example, the prevention of seizures or dysrhythmias or psychiatric conditions. I think that's another similar analogy to this indication. Another reason we may perform TDM is to minimize the time required to obtain and maintain a therapeutic concentration. And this again applies particularly to antimicrobials. The time to an effective antimicrobial exposure must be minimized. We know that time to effective antimicrobial concentrations maximizes clinical outcomes. We can also sometimes get toxicity from supertherapeutic concentrations of some antimicrobials. So there's not necessarily any benefit in overdosing all of our patients to ensure that they achieve their effective concentration as soon as possible. And this principle is particularly important when the therapeutic and toxic concentrations are similar, which is known as a narrow therapeutic index or window. If we look at this diagrammatic representation, this is a plasma concentration on the y-axis and the time on the x-axis, and we can see what happens with every dose. With each of the subsequent doses, we can see that the concentration stays in the therapeutic window more often than early on. We're lucky in this case. It really only took 2, maybe 3 doses until the drug was mostly in that therapeutic window. We can see in some cases, though, the concentration is outside that window. Maybe that's important. Maybe it's not because it's such a short duration as depicted in this image. Similarly, some of the concentrations are below the therapeutic window, which therefore would suggest that they're subtherapeutic. Again, that may not be clinically important depending on the bug. For example, with beta-lactams, we know that time above MIC is an important determinant of cell death, meaning antimicrobial cell death. These transient decreases is probably not important. They're also low toxicity as a class in general, and so these transient increases in concentration may not be important. But we can still see that there is super and supratherapeutic concentrations, and maybe in some cases it could be much more marked, particularly if we're not certain about changes in physiology which may impact on that. And this is an example of a case whereby the concentration was achieved relatively quickly. What about this case? This is a case whereby multiple doses were required for the drug to enter the therapeutic concentration. To bypass that, a loading dose was given, which took it straight into the therapeutic concentration. Then with each subsequent dose, it maintained concentrations within there. We should congratulate ourselves from this. But of course, this is again an ideal situation whereby we know specifically what dose to give to that patient of the loading dose and the maintenance dose. But in the event that they had other medical conditions, for example, they're in a wheelchair, they had sarcopenia, so we didn't really know their kidney function, or they had an amputation, or they're in intensive care with sepsis, or they had end-stage kidney disease. A whole lot of other factors would change their physiology, and therefore that may make this loading dose overshoot or undershoot, and similarly the maintenance dose. Even if the loading dose is correct, maybe we'd get accumulation, or maybe we'd get subtherapeutic concentrations. So even with smart approaches to dosing, for example, giving a loading dose, it is still necessary to make measurements of the concentration of the antibiotic to ensure that it enters the therapeutic index and it stays, the therapeutic window, and it stays there. So another reason to perform TDM, as introduced on the earlier slide, is for the patient with variable kinetics. Altered physiology causes altered organ function and vice versa. Many antimicrobials are hydrophilic and largely cleared by the kidneys. Therefore, they're very prone to changes in kinetics in conditions such as sepsis, which are associated with changes in volume and kidney function. As mentioned, we can have acute and chronic decreases in GFR, which will require a change in dosing of many antibiotics. And in some circumstances, we can have augmented renal clearance. This is where, due to an increase in the cardiac index, there is an increase in clearance of the drug through the kidney due to the hyperdynamic state. So all of these factors also are dynamic and change frequently. And it is difficult for the clinician at the bedside to be able to incorporate these changes in physiology into pharmacokinetics, into the change in pharmacokinetics and therefore the change in the dose. But there are many other factors as well, such as the impact of age, which can change clearance of volume distribution. Pregnancy, generally increased volume distribution, increased clearance. Body weight. The impact of body weight depends on the drug we're talking about. If someone is obese with a large a reserve of adiposity, then a hydrophilic drug doesn't go into adipose tissue, so the actual body weight probably isn't important. And other factors as well that we would all well know. This is a diagrammatic representation of what I was talking about before. So sepsis can cause an increase in cardiac index, increased clearance, and therefore cause lower serum concentrations. Leaky capillaries or altered protein binding can increase volume distribution, cause low serum concentrations. If you've got end organ dysfunction, this decreases clearance. This can cause a high serum concentration. So in the same patient, they're competing processes, and it's very difficult to ever know what these are. Many are reversible, and therefore close monitoring is required, and TDM is ideally placed to assist us with that. Let's talk about some of these factors diagrammatically. So this is a concentration time profile. The black line shows the impact, shows the normal kinetics of the concentration going up and coming down. This happens to be an orally administered medicine. We can see that doubling the volume distribution will cause a decrease in the Cmax. It decreases by half, but a prolonging of the half-life. A halving of clearance will cause a slight increase in the Cmax. As mentioned, this is an orally administered medicine, and a prolonging of the half-life. So this concentration time profile, the impact of disease, may impact on you achieving your target concentration for your antimicrobial. If Cmax or AUC is important, then the dosing from a change in volume distribution may be important. If time above MIC is the important factor, depending on where the MIC is, then either of these factors might be okay. But what is the impact of toxicity? What is the determinant of that? So we can see here that with these simple changes in pharmacokinetics, very different changes in concentration time profiles can occur, and this can impact on us achieving our targets. With repeated dosing, this becomes more important. We can see that with a halving of clearance, we get rapid accumulation. If there is no change in dosing. With a halving of volume distribution, again we get accumulation, but much slower than we get with clearance. And imagine what would happen if we had both factors changing, and they continue to change at unpredictable amounts, the overall impact on the concentration time profile is very difficult to ever guess. But on that simple example, perhaps the best way to fix that is just to double the dosing interval. As we know, the doubling of volume distribution or halving of clearance doubles the half-life. Therefore, if we double the dosing interval, then we won't get accumulation. We can see that here, the black line with the usual dosing interval. If we double it, with the blue line, no accumulation. With the red line, no accumulation, even with repeated dosing. But as mentioned before, we get very different concentration time profiles, and depending on our target of Cmax, AUC, time above MIC, this may be clinically important. And we can see here also that with the doubling of the regimen, we only get to have one dose when there's altered kinetics. And as mentioned, with most patients, both are changing, both clearance and volume distribution. And so it's hard to know which of these reflects our patient in front of us. Another reason to perform TDM is that it may predict the risk of toxicity. This may guide further dosing, for example with aminoglycosides, but sometimes can also inform a differential diagnosis. For example, a patient who has confusion who is being treated with cefepime. It can also be helpful to confirm adherence, and this is less common indication for antimicrobial therapy. So to the topic of aminoglycosides, as you know, it's the Cmax to MIC ratio that is a major determinant of the effect of aminoglycosides. In my patients on dialysis, if I think there is a clinical indication to give an aminoglycoside, and I've done this on a number of occasions, I can do this and I can give this pre-dialysis. So we can get a high concentration. Due to the efficiency of our current dialysis technology, then there is elimination of the drug during dialysis, so it comes down to a low concentration. And because the patient doesn't have much residual renal function, the concentration decreases at a very slow rate after that. But we can see the concentration is generally low. If we compare that to the effect of giving that same dose, which achieves a high concentration after dialysis, we can see here that the concentration remains high for very long. This may risk toxicity, such as ototoxicity. If we give a low dose after dialysis, it doesn't achieve a very high concentration, and it remains higher than would be seen with the pre-hemodialysis concentration. So here, I would measure a gentamicin concentration here, or whichever aminoglycoside I'm giving. And the reason for that is that I want to know that there were no problems during dialysis that prevented the drug from being cleared, and therefore prevented the concentration dropping so that my patient's risk of toxicity was reduced. This is a particular role of hemodialysis. If it remains elevated, then I'll be very cautious about giving this drug to my patient again, and I'll also be reviewing what is happening on dialysis to reduce their overall solute clearance. We also need to be aware of possible assumptions and limitations of TDM. And there's multiple important factors. First of all, what is the evidence supporting TDM in an individual case? And I mentioned this earlier. Is the data that you're looking at generally applicable, or is it based on a very specific group of patients which were different to the patient that you're treating? It's important to remember this. When we're looking at how an antibiotic concentration predicts a response, as mentioned, we need to ensure this is preserved across a group of patients. Maybe it also depends on the site of the infection that's being treated. For example, if specific drug targets, antibiotic targets were described for the management of bacteremia, they may not necessarily apply to the management of cellulitis because we're treating a bacteria that is in a different compartment when it's in the tissues compared to that in the blood. The laboratory is very important. If the laboratory is not performing well, then there's not much point in doing TDM. Importantly, the measured drug concentration should relate to the active compound. This includes components such as accuracy and precision. Are there metabolites we should be measuring? These, in particular, if they're active metabolites, or even if they're toxic metabolites, that may become a key factor to know. Are there cross-reacting substances? Some of the older forms of drug analysis were based on ELISA technology, and they could cross-react with other substances. Fortunately, this is less often seen now. What is the impact of protein binding? We don't have time to talk about that today, but it's important to remember. And also, what is the health system in which TDM is being utilised? Are the timing of blood samples appropriate? Do they need to be at steady state conditions? In the old days, or even for many drugs that we're looking at the moment, trough concentrations are important, and therefore if the drug concentration is not obtained at a trough, then it may not be easily interpreted. Fortunately though, with increasing technology, we are able to use various dosing software which can help us to adjust for concentrations that have not been obtained at trough. Indeed, they can be more accurate if they're obtained during the dosing interval, and therefore this can be of assistance. Therefore, the use of TDM to a degree will depend on the health system that you're utilising it. What's also important is that the concentrations are available in a useful time frame. So what is the impact of TDM on the prescribing process? Well, the prescribing process is an iterative process, and this applies equally to antimicrobials. After an appropriate starting dose, the regimen is changed to achieve the target. For many medicines, we prescribe as a start low and go slow approach. This doesn't really apply to antimicrobials, where we generally start midway and then titrate up or down depending on the effect. The therapeutic target may vary between individuals, including the condition being treated, the anticipated outcomes of therapy, of which, of course, cure is the usual endpoint with infections. So in summary, regarding the TDM of antimicrobials, you need to give an appropriate start dose. What this is depends on the antimicrobial indication of patient. You need to measure something. In the case of antimicrobials, we're measuring drug concentrations because pharmacodynamic endpoints are changed too slowly. We need to compare this against a proven target concentration. This is informed by evidence. What this concentration is depends on the drug and in some cases the condition in the patient. This is an evolving area, which is why workshops such as that being held today is exciting. And we need to make appropriate dose adjustments if required. And this really does require some expertise and increasingly other support such as dosing software, which similarly require expertise to use. Thank you.